This episode is brought to you by the American Academy of Orthokeratology and Myopia Control. Go to aaomc.org and join us. Join the war against the myopia epidemic. All right, welcome to the Corrected View podcast. We are a podcast about myopia control, ortho-K, and developing a specialty practice. And this podcast is brought to you by an organization called the American Academy of Orthokeratology and Myopia Control. And it's important to mention that it's made up of hundreds of men and women who are super passionate about eye care. And one of those members is none other than Dr. Nick Despotidis, who has become one of our regular monthly co-hosts. And the reason why is he runs a fantastic workshop called Supercharger Practice, which previously we ran alongside Vision by Design. And Nick, I remember going back to the first time we implemented the two programs together. Right. And I was just a snot-nosed kid, just trying to make sure projectors were in the correct rooms and that everybody was signed into our meeting correctly, our annual meeting. And I remember people saying, Supercharger Practice, what can you tell me about this? Should I sign up for it? And I just looked at him. I said, look, I don't know anything about it, but if Nick's running it, it's worth taking, right? That's what I told people. And that's how we started together. Yeah. And it's grown into this thing that, every year at Vision by Design, I have people who come to me, even though the registration for it is done through you guys. I have people who approach me at the meeting and say, it's sold out. Is there anything you can do to help me get into this workshop? Yeah. And so, I hate that we can't have in-person meetings in Vision by Design. And in lieu of having to cancel Vision by Design and not being able to have Supercharge, I figure why not have Nick on with us once a month? And we'll go over practice management questions. So Nick, welcome back to the podcast. I know that was kind of a lengthy introduction, but I was just kind of cycling back to the years in the past and remembering fondly when we could meet up in person.
And I appreciate that very much. And I remember when you just started and I just started Supercharge, I'd get half a dozen doctors attending. Mm-hmm. And up to COVID, we were over 100. So, and I remember emailing you once COVID hit. I said, look, we got to keep going. And you were gracious enough to say, yes, I think we should. And the nice thing is, even though we're not in person, the clinical tips that I share today are shared at Supercharge. So they're getting the benefit from home. Hopefully they're following through on some of my recommendations.
Definitely. This is going to be a great value to people, especially now, but also in the future when we can have in-person meetings, and being able to come back and listen to these questions that we get from you guys, the audience, from people who have been interested in Supercharge. Sometimes they've attended Supercharge and they have follow-up questions for Nick. Sometimes they come from our members. Sometimes they just come from our listeners. And if you have a question for Nick, then send that over to thecorrectedview@gmail.com. We also have a Facebook group, and we also have a Discord server, which is real-time text and chat for our members. And if you want to become a member of the organization, you can do that at aaomc.org. Okay, so Nick, let's get to our questions. All right, so this has to do with people who are still having a hard time capturing patients for myopia control treatment. And we have two questions. The first one being, do you have a system in place to follow up on myopia control candidates?
Yes, I do, and everybody should. I think this particular question is discussing when this doctor makes a recommendation for a child to undergo some myopia control treatment. Mm-hmm. They may not be converting. So we're talking about lead conversion or converting a possible patient that needs this treatment. And I think it's important for everyone to have some type of outline of procedures they go through. So this is how it goes through in my practice. Is the first thing in the exam chair during the primary care exam, if myself or any of my doctors notice a child who is nearsighted, who would benefit from a myopia control consultation, they'll recommend just that. is they'll recommend a consultation. We don't recommend ortho-K or atropine or any other modality in the exam chair at the time of the primary care exam. Just like we wouldn't start treatment for glaucoma or any other treatment right in the chair. We have them come back for some type of evaluation or consultation. So that's the first tip, is that you have to realize that you're going to have to present this to quite a few parents before one takes it. And that's what I teach at Supercharge. I have found doing this for a number of years, I have to recommend it to 7 good candidates for one to transition into a consultation. So don't be discouraged. This is something, even though it's been FDA approved for 20 years, it's new to parents. They have to be interested in some form of myopia control. So don't be discouraged. So the first step is have a consultation. And everybody's heard this before. Number 2, here's another key tidbit, is most of my patients, I would say over 90% of my consultation, do not come from my exam chair. They come from friends and family. And Matt, we've talked about this in past podcasts.
Yep.
So the key is to make this event, if you will, this consultation, worthy of discussion at the school, at the soccer field, amongst family gatherings, so that your parent can educate parents before they come in for the consultation. But let's say you don't have that luxury, because I've been doing this a long time, is now before the consultation, this is a key ingredient. I do a phone conference or virtual conference. This is new since COVID. We discussed this last time.
Right.
But it has helped me tremendously, because I think what this doctor's referring to is that when they have a candidate, they don't transition into their program. So what it starts is with a virtual call where I sit down and I talk with the parent virtually for about 15, 20 minutes. I call this a parent conference. And I schedule it using Google Meet or Zoom. And we talk about things you don't have time to discuss in the exam room. You know, is your child on a computer a lot? Are they learning remotely? Do they watch a lot of YouTube? What do they do on their downtime? Do they like to read? Do they play outside? Are siblings nearsighted? Are parents nearsighted? What age did the parents become nearsighted? We even go to the grandparents. And then I have a nice history prior to the child entering the consultation. And if I could tell you right there, that's such a huge tidbit that I've invested in since COVID began, and I'm going to keep it long after this pandemic is over. So then when the child comes in, I'm sorry, go ahead.
As soon as you mentioned the family history, because you're definitely not the first doctor that I've heard does this. Carrie does this. It's very important. Wow. I'm sorry to interrupt, but
no.
Why is that so valuable? Because I feel like what you just said is very important to get that family history, because Carrie covers with a patient like their nutrition habits and all sorts of details. He asks you lots of questions. So I don't want to skip over that part, because family history is super important. So why is it so important?
And lots of questions is very important. I have found that parents who are interested in myopia control have a lot of questions. And during our exam time, our 20-minute allotment, half an hour, 15-minute allotment during an exam, you don't have time to address these questions or ask these questions. So family history is critically important for a number of reasons. One is we know that myopia progression has at least a genetic component. We could all agree upon that. We can say there's a multitude of factors. Nutrition is very interesting, because I talk about that as well. Basic nutrition, because these poor kids are learning virtually now. They may start at 8:45 and go straight to 1 o'clock with minimal breaks. And I ask the parents, do they have a glass of water, hot tea, a snack next to them? And a lot of times these kids are dehydrated, let alone basic nutrition. And these are questions that Carrie obviously asks, and many of us ask, but are critically important and during these times where many of the kids are still quarantined, they're at home glued to their computer. The family history also is important, because there's a certain level of guilt involved. When a parent is myopic, they're hoping that they haven't given this gene or their environment to their children to cause them to be nearsighted. So there's a big difference between a parent who started wearing glasses in college and now are -4 myope, as opposed to the parent that started in first or second grade and now is a -10 or -12 myope.
Right.
And this is so critically important because during my consultation now, I really know how aggressive I have to be. I know the age of the student. I know approximately their refractive error, and I know how strong of a family history there is. I also know their environment. Many of these kids haven't gone outside in 6 months. Some kids have, and they still progress in myopia. So these are all factors that are so important. I got them out of the way. So when this child comes in, who's usually between 10 and 12 years old, I can fully concentrate on their experience, not on getting a history.
Excellent. Yeah, I think of the book that you wrote, My Kids Are Nearsighted too.
Yeah.
Where the opening part of that book is you mentioned that you and your wife didn't need glasses or contacts or whatever the case may be until you were in college.
Right.
And with the increasing incidence of close work and, like you mentioned, kids not going outside. I mean, pre-pandemic, we had a problem with getting our kids outside.
Right.
It's a major issue. Whenever I talk to friends or whatever the case may be, and those questions come up about like how much time should my kid be in front of the computer, and I said you should be asking how much time are my kids getting outside, because it's very important. And so when you mention that, that's the first thing that pops into my head is, the emphasis of establishing for that parent, like, look, you may not have needed glasses until you were in college, like in your life experience, and now your kid is in this particular case, and so that's what strikes me when you had mentioned that.
Right. And just think, for the doctor out there who's asking the question, and so many other fitters, what they're focusing on is, how do I convert this prospective candidate to my treatment program? I'm saying, kind of like, do a shift, a kind of thought shift where it starts the minute you say hello. So just think, this child now comes in for their consultation. I have a detailed history that I don't have to do during the actual consultation. Two, and we've discussed this in previous episodes, I kind of know what kind of enjoyment they have. Is it Pokemon cards? Is it fidget spinners? Is it water balloons? Is it something that really will entice the child, like a Lego set? So during the consultation, not only do I know their video habits, their nutritional habits, their genetic background, but I also know, what does this child enjoy? So when they're coming to my office, they know they're going to get snacks. If you remember last time I showed you my snack drawer. But in these times I have to up the ante. I also get a very menial but very important toy for the child, like a Rubik's Cube. And now the child, instead of worrying when they're coming back to the eye doctor about what they're going to do, are they going to put drops in my eyes? Are they going to put a contact lens or OK lens in my eye? They're thinking about, wonder what I'm going to have to do to get that Rubik's Cube or a deck of Pokemon cards. This is a nominal expense, menial expense. We're talking less than $10. But I'm going to tell you, I track everything. And what I've noticed post-COVID, when I've instituted this virtual conference, my conversion rate has gone into the mid-80s all the way to the high 90s of conversion, just by having this 15 or 20-minute conference. So that's just a clinical pearl now for everyone to implement. It is a pain. It's 15, 20 minutes of my time, and then the busier I get, it's multiple parent conferences, but the consultation goes a lot smoother.
Right. And just having that extra, moving forward, that's going to be an essential component of your practice, even past COVID, even when things get back to somewhat state of normal.
That's right. That's right.
You got to use every tool you have.
Absolutely. So when they come in for the consult, I do what most of us have learned to do. I get a bunch of preliminary testing, very accurate topographies, etc. But now when the child is in my exam chair, I can focus totally on this child's experience. I already have the data. I could fit this child right now without even a diagnostic lens, but that's not the goal. The goal is to make the parents feel safe when their child is in my hands, and also feel that they're giving their child the best treatment. And the way you do that is by answering questions. It's not by the best fit. It's by answering the questions. And that allows me the time. So it takes me 15, 20 minutes to gain the child's trust, to get my refraction, to give them the snacks that we talked about, to show them the toy that we got prior to the consultation. And then the big step, especially if you're going to try Ortho-K lenses, is to put a diagnostic lens in their eye. And we do this for two totally different reasons. One is to see the child's reaction and the parent's reaction, and two, to get an idea of, is this child a good candidate with how the diagnostic lens fits and what lens I'm going to fit them with. So it's two separate purposes. The most important being, how does this child react and how does the family react when the lens is in their eye? So doctors who fit empirically or doctors who fit directly from the topography, that's fine, but you're missing a golden opportunity to have the parent entrust you with the care of their child, because you don't want these surprises at the insertion and removal class. Trust me. If the child's going to start crying or complaining, you want to address those questions right in the exam chair. And how you do it will determine if they're going to sign up or not. So now I go through my consultation. We try on diagnostic lenses. I promise you one thing. When that child leaves, they're happy. They're happy because the lens is out of their eye. They have a nice snack treat. And now they have like this nominal toy, which means a lot to them. So they're leaving happy. And now I've left plenty of time for questions. We've addressed this in previous podcasts. I can now focus on the parent and answer all their questions. And then my staff presents our program to them. So currently, at that point, about 9 out of 10 families convert into our program, assuming they're good candidates for whatever it is, whether it's atropine or dual focus soft lenses or Ortho-K, and majority are Ortho-K. Let's say at that point they're not ready to make a decision, which happens about 5% of the time. We get a report out to them within 24 hours, and it's a detailed report. It says, dear parents of Matthew Herzberg, we found these details, and the history I took during that virtual call is there. Matthew likes to play with electronics. He enjoys YouTube and playing video games. He also is an A student. And it's all in there. All that virtual history goes in there, and I humanize it. And I say, this was his prescription last year, if I have that data. This is the findings of my examination. This is what I recommend. And this is here's the data. I give the parent the data, because most parents who are interested in myopia control for their children are doctors, engineers, rocket scientists, pharmacists. They like data. So when people say I have a system, I give them the topography. I give them the retinal photographs that I took. I give them my recommendations. Your child's not playing outside. I use the myopia profile. And basically, I say, they're not playing outside. You have a genetic predisposition. Your child is now at a higher risk or a low risk. And this is, I extrapolate, your child's now 10. Here's the data where I project them to be when they're 18. So I give them all this in a nice, good-looking packet. And I send it to them. They get it in a day or two. I ups it. It goes like, they get it in a day or two. Because maybe they're going to a competitor of mine. Maybe they're just decided not to decide. One thing we know about myopia, doesn't get better. So if they decide not to decide, their child's myopia is probably going to progress. If they go to a colleague of mine, not a competitor, a colleague, then that colleague has big shoes to fill. Virtual phone call, 1 hour consultation where I make the child at ease and the child's happy. And I've answered all your questions after you answered all my questions. And that's why it jumps to 95% conversion rate. And that's how this whole package is, from the point of a parent shows interest in Ortho-K, or I show interest in recommending it, to the consultation is over with this packet they hold in their hands.
I love that you said colleague, not competitor,
Yeah.
because that's definitely a theme in the AAOMC. It's one of the things that makes our meeting Vision by Design what it is, that makes what our community is, because that's the attitude that
Yeah.
our members have, is you're not a competitor, you're a colleague. So I was hoping that you could go a little bit into why that is, because I've been to other meetings, and there are other great meetings where people share information, but I've never seen anything like our meeting that has that strong
You're so true.
vibe.
You
Why is
started out this webinar or this podcast with Supercharge. I'd say the majority of attendees come from the tri-state area, and most of my colleagues in this area have taken my course. So they are competitors and they are colleagues together, but I don't view them as competitors because when I didn't have people doing Ortho-K, the number one question patients asked was, why don't other doctors do this? Now, that's not a question I get often. The question I have to ask within myself is your child right for my office, and am I right for your child? And this works out great, because when the sun shines on me, it shines on all of us. And when it shines on the doctor across the street, shines on all of us. One thing I've learned from doing this a long time and meeting people at these conferences is we all do this same technique of Ortho-K or myopia control differently, and it works. There's no one set way to do it. We all do it the way we're most comfortable with. So, for example, I may like the toys and the snacks. My colleague, even within my office, that doesn't ring their bell, and that's fine, because you know what? A lot of parents don't like that.
Right.
Maybe they want to go to someone who's more cost effective, who's closer to their house, who doesn't want the frills of the parent conference. I'm not the office for them, and vice versa. So when I go to this, when we have the annual meeting, that I hope we have soon, what's joyous about it is we all talk amongst one another and share clinical pearls and say, I do it this way. No, I do it this way. And there's no right or wrong way. Once you get through the basics of the Ortho-K, it's how we treat our patients when they're in the exam chair.
Right. Yeah. And the perfect example of that was, and I'm forgetting the name of the product. It's not important, but it was a solution or a set of drops. And Kerry swears by it in his practice. It works very, very well. And I remember a while ago, we got a shipment into the practice from your practice, and Kerry was like, "Oh yeah, here's the stuff from Nick." And I was like, "Well, why did he send us boxes of?" It was like drops or a solution, I think. And he said, "Well, we were talking, and Nick says that these don't work in his practice." And I was like, "That's crazy, because this works is amazing in your practice." And it really speaks to, it's like the one detail, one product, one minor detail, or however you guys do things differently. And it's like I believe you were just like, look, this isn't working for me. You like it, I'll just send it over to you. And that's an example of the kind of camaraderie that's in our academy. People are like, I'm having trouble with this, or what kind of lens designs do you guys use? I had a patient come in today that, this was the issue. What do you guys think? And I love, that's what we built this whole academy on, was that network of people who are like, look, the patient, we want to address the global myopia epidemic, and we want to be better eye care providers. And we can only get better by sharing information and being there for each other. Right.
And I want to give one other example, and I talked about this last podcast, but I want to give kudos to the doctor in this forum that you have, the Academy Forum. I remember during COVID, I post a blog post on how I think this telemedicine is overrated, that our whole profession was focusing on telemedicine, billing telemedicine. For me, my practice, it wasn't working. And someone so acutely said, a member said, hey, Nick, have you thought about how you could use this for your specialty care patients? And that's where the virtual phone conference came in. So you could see, there's like, boom, wait a minute, I'm just thinking so narrowly, coding, billing, conjunctivitis, where this doctor is thinking much larger than me. And it's like, how would this help us for what we do? And that's where the whole virtual conferences came. So you're absolutely right. We all help one
Awesome.
another.
Yeah.
When the sun shines, the sun shines on all of us.
Right, exactly. So back to that first part of the question, as far as the system for following up on a candidate, do you send them home with this packet of information, you spend lots of time with them, and these are very key elements to securing that person's going to become part of the program. But what do you do about the patients that it just isn't sinking in with? Is there an extended system? Maybe you
No,
see them
this
again, or
yeah, this is another great question. By the way, I don't give them the packet right away. We
oh,
send
okay,
the packet to them because it takes me a while to derive. It has more value that way. They
right,
get it in the mail. They get paper, which is now
hmm,
very unique, as opposed to
right,
something electronically, and they can do whatever they want. We do email them a week or two afterwards and say two things. We want to make sure you receive the packet and make sure you don't have any further questions,
hmm,
because the data we collected during the consultation is good for 2 or 3 weeks, at which time you have to come back and I have to recheck my data, because everything we do is based on that initial data. So it gives them some sort of deadline that, I
okay,
have to make a decision. If they decide not to decide, they go just back. The next year they come in, if they come back, it says right there, presented myopia control, ortho K, whatever we presented, and we present it again. And sometimes you just have to be patient. Myopia doesn't get better. If they're going to go for this, they're going to
right,
go on the second or third or fourth year their child progresses. That's why it's so critically important to impress these current patients, your current patients, because they are the ones that are going to advocate for you on the soccer field, in the Chinese school, in the regular school, in the family gatherings, because then the bar is low. It's like, oh, this practice has been recommended to me. I kind of know what's going on. Child sleeps with the lens, been wearing it a few years. Their eyesight hasn't progressed much over the years. I know Johnny who wears them. So just look how much easier my consultation is, as opposed to someone blindsided by saying, you know what, instead of increasing the power of your soft contacts or eyeglasses, there's another option. Well, that's a big learning curve at that point for the
hmm,
parent. And so for the doctor gets discouraged. This doctor shouldn't get discouraged. They should follow my protocol that I just outlined with them, make it their own. I promise you, it works.
gotcha. And that raises another question, which I don't know if this is an uncomfortable question or not, so I apologize in advance, but it's a question that I hear quite often, is that some eye care providers who do myopia control charge for these consultations,
Yeah.
and some do not. And I thought, why not ask Nick, do you charge for that consultation? And if so, or if not, why?
This is a great question. The answer is yes, but I didn't for the first 10, 12 years. I was scared to
Okay.
death.
Okay.
I'm embarrassed to say it. And I give hours away. And the reason I was scared, I was like, I figured they're going to love me.
Hmm.
They're going to love my office. This is Dr. D. And it worked. It worked really well. At that time, I could tell you, we would get about 87% acceptance. And then about 5, 7 years ago, Matthew, something happened. My conversion rate dropped to low 80s. And once it hit about 76%, which is not terrible, right? 75%. 3 out of 4 patients would enlist in our program. Like, this is not working. I'm getting window shoppers. I'm getting people which are benefiting from an extraordinary event, just giving away my time. So now we do charge, we call it share cost, about an hour of our time. We still don't make money from the consultation, but now that basically shows us how interested are you in arresting or slowing down your child myopia.
Hmm.
And even though at first we took a hit, now there are quality patients in my chair,
Right.
and the conversion went up. And that's really what I'm interested in. I
Right.
don't want to just educate you and leave. I want you to enroll in my program. The other thing we've done is we ask for a deposit. And I notice when I go to a specialist that doesn't run late, they would ask for a deposit for me. And what they're basically saying is, like, we're reserving this time for you.
Right.
And that this deposit assures us that you won't show up, because when I didn't charge for a consultation, sometimes I got no-shows, and that hurts, because the way we quantify our success is we allow certain consultation visits per week, and we monitor how often they're filled and how often they convert once they're filled. So we go that far doing it. So I've done it both ways. And what I was going to make a recommendation, I would charge right now for a consultation, whatever you feel comfortable with, because that shows how serious the parent is.
Right.
That was a good question.
It also shows how serious you are, because you're basically saying to that patient, look, my time is valuable and this is an investment, and I'm not going to waste it on somebody who's not going to be invested. Like, we all like to make money. We all want to be successful, but I'm sure there's many optometrists who can relate to the, no call, no show, and then you give them another chance and they do it again, and then you give them another chance and they do it again. And at what point are you going to say, look, this isn't worth it? Like, you're just stringing me along. So,
and the thing that helped me with this is that many of my colleagues don't charge for it, and some parents value that. That's good. Same thing with this no-show fee. My fear was when a patient showed, like primary care, we have a no-show fee. And basically, my fear was, if I charge you, that you'll go to my competitor or my colleague. It's okay. You can't be everything to everyone. And I think in optometry and ophthalmology, we feel we need to be everything to everyone. And we cannot. You can't prosper being everything to everyone. It's okay if they are serviced by some other eye care practice. It's fine.
Yeah, for sure.
It actually works in our benefit in the long run, to be honest with you.
How so?
Because sometimes they say, oh, okay, now experienced Dr. D's office and Dr. Tannen's office and Dr. Lee's office, and I've experienced Dr. B. And she's very nice, but she may not be the same, and they'll come back. So the thing is that parents talk, and that helps us. It can hurt us, it can help us. The community talks, and when a parent's not being serviced to, their child is not cared for to what they expect, word gets out. And then price becomes a non-issue at that point. It really doesn't. Whether you pay little or a lot, depending on your standards, what matters most to a parent is how well their child is cared for.
Right. Yeah. You're not just offering an ortho-K treatment. You're offering a practitioner that cares about your child, that takes this seriously, is willing to spend the time with the patient and the parents. And let's face it, like, that's not what the standard of care is out in, regular optometry. That's why docs come to the AAOMC, because they got sick and tired of just rapidly seeing patients at the behest of, chair time and keeping up with insurance and whatnot. So, I like the idea of being like, my experience is unique and special, and I'll spend the time with you, but it's valuable. And I think people ultimately respect that, whether you charge for your consultation or not. I think if you can impart the ideas that we've talked about in podcasts up to this point and this one, about imparting that you are special, that this is a special experience, and you, the practitioner, are invested in that experience and that patient, I think that goes a really far way with them. So
yeah, and I don't think it's the ortho-K experience that makes you unique. It's the interest you have in ortho-K to come to the conferences, to join these groups. I find that very similar to vision therapy docs. We care, we practice a certain way. And all we want is, like you alluded to, is to reimburse for our time and expertise. And sometimes we just have confidence in it, So you see that in the Accord group that you have, a Discord rather.
Right, Discord, yeah.
A lot of people are intertwining vision therapy and, it's not just using a contact lens to reshape the cornea. We realize two things. One is there's a child behind the cornea that has a binocular system, that has a unique personality. And number two, and we should end on this, is that this is a childhood, if not lifetime, procedure. It's not like a contact lens procedure where I fit you and I'll see you in a year. We just changed our agreement to reflect that. When parents enlist in our program, they got to know this is a lifetime, if not a childhood procedure. We're going to see your child through elementary school, middle school, high school, college, and beyond. So just don't think this is going to end in a year or two.
Right. I have so many I have so many more questions for you, but
Yeah.
I know we only have you for a little bit about a time, and those are future episodes. So I think we'll take a break at this point,
Okay.
unless there's anything else you want to add, and then we'll address our second part of the question, which I'll just put that out there before we go to break, which is the second part of this question is, I gradually increased my fees. I wonder if they're too high, since most don't sign up even when their children's eyesight progresses over 1 diopter from the year prior. Okay. So we're going to talk about that one right after the break. This podcast is made possible by the American Academy of Orthokeratology and Myopia Control. If you want to learn how to do Ortho-K, then we can teach you. If you're looking for a passionate community of like-minded experts, then consider becoming an AAOMC member. Or if myopia management just isn't your thing, that's okay too. Use the AAOMC online doctor search tool to refer your myopia management patients. For more information, visit AAOMC.org and join us. Join the war against the myopia epidemic. All right, and we're back with the Corrected View podcast. We have Dr. Nick Despotidis with us from Supercharger Practice. We have Nick on to help us answer practice management questions, Ortho-K questions, myopia control questions, and we are going to address the second part of this question, which is, I gradually increased my fees. I wonder if they are too high, since most don't sign up even when their children's eyesight progresses over 1 diopter from the year prior. So I guess the crux of this question is, how do you know what the right fee structure is? If you think you set your fees too high, like, what is the barometer that you need to use to figure that out? Nick, what do you think?
Well, you can talk about chair costs. We could do it another time, because that's really the business related answer. Is if you look at how much it costs to run your practice every hour, and you make sure your fees reimburse you for that. But I like to view this as the gut question. If you're providing a service and you feel good about providing the service, it's most probably due because you're being reimbursed properly for that service. So, for example, if you're accepting a vision care plan, and when you see it and you look at this plan, you go, oh, this patient's from this plan ABC, you're not being reimbursed. It doesn't take, chair cost analysis. So in this doctor's case, to answer his or her question specifically, is that your fees have nothing to do with your conversion rate. You have to look at your procedures, because I have charged over my, like your dad, I've been doing this for decades, and I've charged a variance of fees. And I notice the fees are not correlated with conversion, despite what my colleagues are charging. That's just the story I'm telling myself. What depends on is how good or sloppy my systems are. So this doctor has to look at her or his systems. If you give the virtual phone call, you're leaving time for questions. We both said we ask the questions as doctors, but we allow the parents to ask the questions. Then we have to make their child feel safe, and we have to gain the patient's trust. And that takes time. It takes less time when you're recommended from a friend or family member, but it takes a lot of time. So there's a big difference if a referral source says, go see Dr. D, and you come and you meet me because you're a friend, a valued friend, and we talked about this with your dentist experience, recommends me, versus me recommending myself, saying, your son or daughter has progressed a diopter a year. That's a big jump. You need to do this procedure. Come and see me for a consultation. Well, now, wait a minute. This is a lot of me here. So you have to take the time to earn that patient's trust. So what this doctor is lacking is not fee structure. It's really procedures. So we've outlined in this podcast from beginning to end a system of how you take a patient who's nearsighted, who can benefit from myopia control, how you get them to the consultation, what you do during the consultation and before the consultation, how you write a report after the consultation, how you email them within a week or so after they get the report, and you set a deadline, and then you move on. That system in your hands will reap a 90% conversion rate if you just follow that recipe. Mm-hmm. And it doesn't matter what your fees are. And if your fees are low, you'll say, boy, I'm not being reimbursed enough for all this time and effort that I'm doing. And if your fees are good, when they sign up and you provide the treatment you like to provide in the way you like to provide it, you'll say, yeah, this is good. I don't need to do a lot of other subspecialties. This is fulfilling my life, my values. I enjoy working with kids. I enjoy helping them in a unique fashion like Ortho-K allows us to do. And I'm being reimbursed for my time and talent. And that's how you know you're doing a good job. So I would encourage this doctor to follow this protocol and just don't get discouraged. It works. I have no reason to lie to you. I just want to help you because it's helped me.
Would you agree with the idea of, setting your fees high, and then if that's not working, it's easier to bring them down than to raise them up? How do you feel about that?
No, I think, sometimes we're our own worst enemy. Okay. So if you think your fees are high, that's going to come out in your personality. Okay. It's going to come out in your presentation, Set the fees where you think it's fair for your practice at your state. You're going to regulate that once you get referrals and your systems get better and things like that. But the story you tell yourself has to be, listen, if they're going to sign up, I need to at least charge this amount, and I'll be happy. If it starts getting, this was not worth it, then raise your fees. So it's really that gut check fee. And it doesn't lie to you. If you're doing a lot of Ortho-K or Myopia Control and you feel you're running on a treadmill, then your fees are too low. Mm-hmm. If you feel that you're embarrassed by your fees or your fees are too high, they probably are too high for the care you're providing. It's that simple.
Definitely. I feel like a lot of it also has to do with your commitment to your system. And you mentioned keeping track of data. And yes. Maybe I'm a crazy person, but I try to keep track of everything, even in relation to the work that we do for the Academy. When we run a meeting, I keep lots of notes and data on everything we did, what kind of registrations we had, what kind of program we ran, if we have manufacturer breakouts where we bring in our great sponsors to, do like a 30-minute class on something. What time of day we offered it, how long we offered it for. And I feel like when I talk to optometrists at other meetings, and this goes along with the don't dabble concept, is that they start out, didn't work, they kind of lost interest in it. And I feel like it's more important to just keep going, keep trying, keep tuning, because anything, whether it's podcasting or a patient in your chair, if you get it right the first time, I feel like that's lightning in a bottle and run with it. But in my experience, I've never gotten good at anything without failing miserably at it first and then learning from my mistakes.
Yeah, you and everyone else.
Yeah, that's the only, people say, what are you good at? I'm like, I'm good at failing and then learning from my mistakes. That's what I'm good at.
Very funny. That's
that's what my skill is I will fail like nobody else and then sit down and look at what I've done and then adjust from there. So I feel like it's important for us to say, if you're not converting to your myopia control program, or if patients aren't interested, it's do not get discouraged. Keep tweaking your program. And I wanted to ask you about that, your personal, obviously you've been doing this a long time. You've seen high roads with it. You've seen success and failure with it. And so I wanted to, send that over to you as far as how did you develop your program? And maybe there's a couple of pearls that you can share.
Yeah, very slowly. The mistakes I made, like you, I always like to say we failed much more than we've succeeded, but we've learned from both. Mm-hmm. So when I began, I just introduced it to my staff, and shoved it down their throat, just like I do so many other things. So, for example, all of us do this. We start doing punctal plugs or LipoFlow. We're doing that. Or we have a new anti-reflective coating or blue light filter lens. We're going to promote that. We have this new OCT or this pachymeter or whatever the case may be. And they're like, yeah. But what they're really thinking about is what's in it for me. Mm-hmm. So I think the key to my success is getting my staff engaged. And we talked about this last time. Do you spiff your staff? Right. No, you can't. If you do, if your staff gets motivated by incentives, then they're not going to stay with you a long time. You have to answer the question, what's in it for your staff? And for my staff, when I introduced this over 20 years ago, is we were going to drop all vision plans. And they scared, but I said, look, just envision a practice where we don't have to do all these forms and do these gymnastics of selling the second pair first, and all these things, and the paperwork and the audits. Mm-hmm. They're like, wow, that's a good life. But in exchange, we're going to introduce this myopia control concept. Patients can be challenging to deal with. There's a lot of learning curve, but since that time, we don't work Saturdays. We see 3 patients an hour as opposed to 6 or 8 an hour. We've talked about these. These are all benefits that have kept my staff for time. So that's the one key is engage your staff by telling them what's in it for them. Okay. And the other key is make a commitment. I decided long ago, I remember it like it was yesterday, I like dealing with pediatric population. Mm-hmm. I like seeing kids. I like making a difference in their lives that the general eye professional cannot. I like seeing them I like seeing them grow and things of that nature. That pushes my values, my buttons, and that's why I've devoted my practice with it. So if you're just doing the Ortho-K for a revenue stream, and by the way, I get this a lot recently. My phone blows up. Nick, times are different. Would you recommend I do VT? Or would you recommend I do dry eye? Would you recommend I do dry eye? Would you recommend I do myopia control? And they're lost before they even begin. They're asking the wrong question. You could be successful in any of those. Certainly you have examples out there. So what do you enjoy? What really turns your buttons as a clinician? So to be successful, you have to enjoy doing it. It doesn't mean my day is Disneyland every day.
Right.
I would venture to say my day is the anti-Disneyland 90% of the time, because I'd be lying to you. Right. But that 10% makes up for all the other hassles that I endure, like we all endure in private practice.
For sure.
So it's nice to feel that there's someone out there that goes happily along their day, every day, doesn't fail like you, but they're all fooling themselves.
Right.
Oh, my watch is having trouble hearing me. So, anyway, that's my advice. It's generalized advice, but it's damn good advice.
It is damn good advice. Yeah, for sure. And that's why we have you on. I think we're going to end it there unless there's anything else that you wanted to add. I've got tons more questions, and I'm sure the audience does as well.
Write them down. Write them down, because with each tidbit we gave today, we can just dive into them. Like, how do we keep stats? What stats do we keep? We talked about a lot of stats already. If you notice, I said 1 out of 7 referrals from my exam chair come into the consultation room. That's a stat. I talked about the conversion rate. The conversion rate is the number of people who come in for a consult that convert into the program. And I also talked about a fill rate, how many consults I have per week and how many of them are filled prior to the week starting. So we can dive into that or anything else the members want. I encourage them to send you questions. I'm happy to address any of the ones that I am capable of answering.
And there's multiple ways that our audience can do that. If you're a member of the AAOMC, we have that Discord channel. You'll get an update on your phone. You can chat in real time with hundreds of other doctors all over the United States and the world. And we also have an email group as a part of the AAOMC membership, which allows members to come in, send an email to the entire group with a question, and that also works. You can email us specifically at thecorrectedview@gmail.com, there is the AAOMC Facebook. So please send us your questions. We'll put them to Dr. D, and we'll be able to deliver lots more great content. So
Great.
Nick, thank you so much for coming on.
Thank you, Matt.
I always love talking with you. That's why I'm excited to do this with you every month. So thank you very much, and I look forward to talking with you again next time.
All right. Thank you. Take care, Matt.
You too.
Well,
Bye.
that's it for this episode of The Corrected View. And if you enjoyed this podcast, be sure to thank the standard members of the American Academy of Orthokeratology and Myopia Control, whose annual dues and support make it possible for the AAOMC to put out education, awareness, and content like this. I'd also like to give a special shout out that I'm going to be giving out at the end of every Corrected View episode for 1 full year. And that shout out goes to Dr. Somi O for her very generous contribution at the lifetime member level of our fundraiser. Thank you to everyone who contributed and keeping the AAOMC alive. You are awesome.